Today we are going to discuss a clinical dilemma which we all face day in and day out. That dilemma is a patient with thyroid dysfunction posted for non-thyroid surgery. Few times we are in dual mind about optimization or proceeding with the surgery. In this presentation, we will see how big is the problem, why we are so worried about the thyroid dysfunction, whether it is necessary to do thyroid function test in all patients, decision making in hypothyroidism as well as in hyperthyroidism, and finally the key takeaways. We are not going to discuss about the difficult intubation and the anesthesia management part because it is itself a topic for separate presentation. We are restricting the discussion about the decision making for optimization or proceeding with the surgery. Thyroid dysfunction is the second most common endocrine disorder after diabetes. According to this original article published in Indian Journal of Endocrinology and Metabolism in 2013, the prevalence of hypothyroidism in India is reported to be almost 11%, and that of subclinical hypothyroidism is around 8%. Hyperthyroidism is less prevalent with an incidence of only 0.67%, and incidence of subclinical hyperthyroidism is around 1.27% of the general population. This tells us that out of 10 general population, 1 is suffering from thyroid disease. This incidence increases in patients elder than 65 years who are presenting for the surgery. So the problem is substantial, and we need to have some frame for deciding about the taking up the patient for non-thyroid surgery. Why we are so worried about the thyroid disease? It is because the thyroid dysfunction will have multisystemic effects. There are cardiac and respiratory effects. Patient will have electrolyte and coagulation disturbances. Patient may have anemia. And the most dreaded complications of thyroid disease are mixed edema, coma, and thyrotoxicosis. And these multisystemic effects will lead to surgical complications, intraoperative hypotensions, and patient will have delayed postoperative recovery. First, we will see the multisystemic effects of hypothyroidism. Hypothyroidism predominantly affects the cardiac function. There will be increased SVR, reduced cardiac contractility, decreased cardiac output, tachyarrhythmias due to prolonged QT interval. Patient will have resistance to catecholamines, though the actual serum catecholamine levels will be increased. Patient will have decreased blood volume. All these effects will lead to precipitous hypotension after induction. Increased ADH, decreased atrial natriuretic factor, decreased activity of renin-angiotensin-aldosterone axis will lead to hyponatremia. And patient will have altered sensorium, and patient will have increased effects of sedatives. Respiratory effects are blunted hypoxic and hypercapnic respiratory drive. There will be respiratory muscle weakness, obstructive sleep apnea, reduced respiratory surfactant development. These respiratory effects will cause delayed weaning and atelectasis, leading to hypoxia and hypercarbia. Decreased factor 8 activity along with the prolonged PTT and acquired von Willebrand factor activity will lead to increased surgical bleeding. But prolonged half-life of coagulation factors like factor 2, 7, and 10 will increase the DVT risk, which will require DVT prophylaxis postoperatively. The most dreaded complication of surgery in hypothyroid patient is mixed edema coma and is associated with a very high mortality up to 60%. Mixed edema coma is characterized by altered mental status, which may manifest as coma or seizure, and hypothermia, bradycardia, hyponatremia, heart failure, and hypoapnea. Though thyroid disease has multisystem deleterious effects, current literature does not advise preoperative thyroid function test in all surgical patients. In patients with signs of thyroid disease, you can advise thyroid stimulating hormone levels. While in known case of thyroid disease, we have to accept the thyroid function test done in previous 6 months if those reports are within normal limit. But literature suggests that to do thyroid function test in all neurosurgical patients to detect the central hypothyroidism. Coming to the decision making in hypothyroid patient posted for non-thyroid surgery, we should find out the severity of the disease, whether it is mild, moderate, or severe. and the type of surgery, whether it is elective or urgent surgery. These two factors are important to decide the further course of the management. So throughout remaining presentation, these two factors we will be discussing repeatedly. As per the old school of thoughts, patients with hypothyroidism are divided into three groups. Mild hypothyroidism will have elevated TSH and normal free T4 levels, while the moderate hypothyroidism patients will have elevated TSH and low T4 levels, while the severe hypothyroidism will have very high TSH level and very low T4 levels. Mild or the subclinical hypothyroidism is further graded as grade 1, where the TSH is raised. It is more than 4, but it is less than 10, while the grade 2 patients will have TSH more than 10. And these are the patients where we are more worried. These patients may be having hypothyroidism on stable thyroxine, and if the thyroid function tests are done in last 3 months, then 3 to 6 months, we can accept those levels. As per the current literature, for mild hypothyroidism or the subclinical hypothyroidism, we can proceed with the all non-cardiac surgeries with usual risk. But the cardiac surgery possesses high risk of perioperative complications. Therefore, we have to be more careful. In this latest article published in April 24, the Michel Dell and his colleagues did meta-analysis where they found that compared to euthyroid patients with subclinical hypothyroidism had higher incidence of operative mortality in cardiac surgical patients. In patients with moderate hypothyroidism, we need to optimize the patients to make her euthyroid, which may take more than 6 weeks. But for urgent surgery, which we don't have that much time, so start the treatment and take up the patient for surgery under moderate risk. We have to be vigilant in perioperative period in such cases for the complications which I have already mentioned. For elective surgeries in severe hypothyroid patients, replace the thyroxine. As already mentioned, that thyroxine orally is to be given in a dose of 1.6 microgram per kg per day in young patient. But in older and cardiac patients, we have to be judicious and use lesser dose, that is 25 to 50 microgram per day. And we can proceed once the patient has become euthyroid. For urgent non-cardiac surgery in severe hypothyroidism, we need to give thyroxine intravenously in a dose of 200 to 300 microgram followed by a 50 microgram IV daily. We have to also give the stress dose of steroids. If the IV thyroxine is not available, then we can give up to 300 to 500 microgram thyroxine through rice tube or orally, and then continue daily dose of around 100 to 50 for rapid correction of the thyroid status. But we have to remember that these patients will be under very high risk perioperative complications. We need to arrange ICU for post-operative monitoring as well as, if required, ventilation. Now, severe hypothyroidism in patients who are posted for cardiac revascularization surgery. Patients who require cardiac revascularization are the only subset of patients who may not benefit from preoperative replacement of the thyroid hormone. The risk of worsening unstable angina is very high because there will be increased demand of myocardial oxygen with the starting of thyroxine. So therefore, in CABG patients, replace thyroxine post-operatively and not pre-operatively as we do in non-cardiac surgical patients. Before the process of decision making in hyperthyroid patient posted for non-thyroid surgery, we will see what are the systemic effects of hyperthyroidism. By increasing the heart rate, increase stroke volume, increase cardiac output. Also, because of thyrotoxicosis, there will be tachyarrhythmias and angina. All these will lead to the high output cardiac failure. Metabolic derangements like hypokalemia and the catabolic state associated with severe hyperthyroidism can cause weakness of respiratory muscle. This respiratory muscle weakness, along with the hypercarbia due to increased basal oxygen consumption, can result in mechanical ventilation, which will be prolonged. Increased calorigenesis, hyperthermia predisposes these patients to muscle weakness and dehydration. Most disastrous complication of hyperthyroidism is thyroid storm or thyrotoxicosis, which is characterized by the cardiovascular, gastrointestinal, thermoregulatory, and central nervous system symptoms, and patient will have a very high mortality up to 30%. Coming to the decision making in hyperthyroid patients who are posted for non-thyroid surgery, Patient with mild hyperthyroidism, when presents for surgery, we can proceed with the beta blocker. Preferably use the long-acting beta blockers like atenolol so that a single dose will be sufficient for 24 hours. Severe hyperthyroidism patients will require treatment with antithyroid drugs. We know that the antithyroid drugs are thiazolamides, that is propylthiouracil or the methimazole. Methimazole is preferably avoided in pregnant patient in first trimester, but the advantage of methimazole is that it is long acting and the single dose is sufficient for a day. Along with antithyroid drugs, we have to treat these patients with the beta blockers. Once the patient becomes euthyroid with stable hemodynamics, then we can post such patients for elective surgery. For urgent surgeries in overt hyperthyroidism or in severe hyperthyroidism, these patients will require antithyroid drugs, that is thiazolamides. Along with that, we can also give iodine. The advantage of using iodine is that it will prevent the release of thyroid hormone from the thyroid gland, as well as it, along with the glucocorticoids, which will prevent the peripheral convergence of the thyroid hormones, and the beta blocker will be essential to manage the hemodynamic stability. These patients will have a very high risk of developing perioperative complications, and therefore they will require post-operative ICU maybe 2 to 4 days. Now, this is the recent case which I did with Sujata. This, as I already mentioned, that endocrine disorders usually they are in combination. So this female, she was posted for CA cervix for laparoscopic total hysterectomy. She was obese. She was having diabetes, hypothyroidism, and because of the systemic effects of hypothyroidism, though she was euthyroid with the stable treatment with thyroxine orally, there was difficult peripheral IV access. So we used ultrasound guidance for putting the central line. Intraoperatively, there was hypertension, particularly the diastolic hypertension. Usually, these thyroid patients will have diastolic hypertension and the narrow pulse pressure. Though the heart rate was stable with beta blockers, intraoperatively, the airway pressures were very high because of the not only obesity, but the position which was given was head low. And fortunately, with the drugs which we use today, that is the vecuronium for muscle relaxation and sugarnas for reversal, we could manage her effectively and patient was extubated. We shifted this patient in ICU for the post-operative monitoring for next 48 hours. So to conclude, be aware of the multiple systemic effects of thyroid disease and the specific perioperative complications which can be severe or even fatal. For elective surgeries, we aim for euthyroid state, but it also varies. Suppose the patient is posted for a very minor surgery which can be done under local or under sedation, we can proceed with the surgery. For CABG, start thyroxine post-operatively. Not only for CABG, even for the patients who are posted for angioplasty, we have to start the thyroxine when the angioplasty is done successfully. For urgent surgeries, we have to aim for hemodynamic stability and provide good ICU care for prevention of post-operative complications. So these are my references. Thank you.